So good afternoon or morning, everyone, wherever you may be. My name is Kenley Money. I am the Director of Information Systems Architecture and the APCD Director at Arkansas for the Arkansas Center for Health Improvement. Welcome to the April 2023 quarterly Arkansas APCD Data Users Group. This is our 15th session. For those of you who are new to these sessions, the Arkansas All-Payer Claims Database, or APCD, is part of the Arkansas Healthcare Transparency Initiative, the ACHI, and is administered by the Arkansas Center for Health Improvement, or ACHI. The Arkansas APCD is comprised of private carrier and public payer, medical, pharmacy, and dental claims, as well as enrollment data and provider data. Additionally, the HTI enables the use of key data sets from the Arkansas Department of Health, including Arkansas Vital Statistics data, hospital discharge, and emergency department data. Those two sources are for self-pay and uninsured only. Cancer registry data and medical marijuana cardholder data. We have some Arkansas workers' compensation data as well. We hope you find today's session helpful. Some housekeeping rules before we move forward. Feel free to type your questions in the chat at any time and we'll address them as we can. If not, we'll try to address them after. At the end of today's sessions, we will provide a link to our service desk application where you can enter any question on the or topic you're interested in discussing. The Arkansas APCD can be very complicated. You can request time with our team to address specific questions you may have about how to use and interpret the data. Some of you have taken advantage of that, and we like to think we've been helpful. The link to this deck will be provided in a follow-up email that will be sent at the conclusion of the session, probably by end of day, maybe first thing in the morning. And finally, the next data users group session is scheduled for July 26th, 2023. So I'm going to go off camera and manage these slides here. Let's go to our next slide. Today's agenda was developed using data user input. If you have ideas for topics, please let us know either by entering ideas and/or questions in the chat or by emailing us. Perhaps they'll be on a future data user group agenda. Today's topics include a featured project using our cancer data, assessing risk, outcomes, and disparity in pediatric asthma. I said cancer, that was incorrect. And then another, identifying providers in the APCD data, and then Arkansas HTI data users survey results, latest data release information and data tips, and something new. It's small, but new nonetheless. Our presenters today are me, Kenley Money, our featured presenter, Dr. Akilah Jefferson, and then Kelly Trellett from ACHI. So, Dr. Jefferson, I'm going to introduce you now. Your topic, assessing risk, outcomes, and disparities in pediatric asthma. Dr. Jefferson is an assistant professor at UAMS in the College of Medicine, Department of Pediatrics, Division of Allergy and Immunology. Her current research uses the Arkansas APCD for a population-level approach to understanding disparities in asthma prevalence and management among Arkansas's pediatric asthma population. Her project will allow her to develop predictive tools for identifying high-risk children with asthma in diverse rural regions of Arkansas. So I am going to stop sharing, Dr. Jefferson, so that you can share your slides.
Great. I'm very happy to be here. Let me make sure. Okay. Are y'all seeing the presenter view or the other view? Let me swap that.
And there we go.
There we go. Okay. All right. So I'm going to talk about my project. Number one, thank you for inviting me. Very happy to be here. My project really is born out of working with a group in the College of Public Health, and a few of them are on the call today, and my interest in pediatric asthma disparities. And so the project is a KL2 project, which is funded through the UAMS CTSA, or the Translational Research Institute. So I'll go over some background and a little review, progress to date, and kind of some next steps. So I like to go over this slide first with this pretty map on the right. So my overall research focus is pediatric asthma health disparities and population health. In the project, we already identified the title, Assessing Risk Outcomes and Disparities in Pediatric Asthma. I always show this map to the right. So I'm originally from New Orleans, Louisiana, which is the little star at the bottom of the map, right at the bottom of the boot. And then we're here in the middle of the state of Arkansas and Little Rock. And then I have a star right in the middle of, or at the border of Louisiana and Arkansas, which is really part of the Mississippi Delta region. I'm very interested in that area and understanding kind of risks and asthma in that area, partially for a selfish reason, because a lot of my family is from there, and really trying to understand how we can better serve kids in underserved and understudied places, particularly in the Delta region. So here in the United States, asthma is the most common chronic condition among U.S. children. It has about an 8% national prevalence rate, and it's more prevalent among Black and Puerto Rican children compared to white children. We know that there are differences in outcomes by race and ethnicity, gender, insurance payer, sociodemographic status, and geography. And here in Arkansas, about 10% of kids have asthma, it's an average, but in some areas, in particular that Mississippi Delta area, there's about a 19% asthma prevalence. There have been some studies here in Arkansas. Most of them were done in the early 2000s, looking at asthma in urban areas, so mostly Pulaski County, and then rural areas, 1 or 2 counties in the kind of southeast Delta region near the border of Arkansas and Louisiana. And in the first study, they found these high rates of at-risk children in both urban and rural areas based on frequency of their symptoms, asthma reliever medication use, and activity limitation. And these were mostly survey studies. And then also found that rural children were more likely to have moderate to severe asthma. In another study of just rural children in the Delta region, they found high reliever inhaler use with about 32% of kids who used albuterol daily. So albuterol is really an as-needed medication for acute symptoms. And then also they found inadequate controller inhaler use with almost 50% of all kids using no controller despite having persistent asthma and persistent asthma symptoms. So controllers are the mainstay of guidelines-based therapy for asthma. And any child with persistent asthma should be on a daily or twice daily controller inhaler. To date, there are really no large statewide analyses of asthma. These 2 previous studies, as I mentioned, were mostly in very small numbers of urban counties and school kids, and they were survey-based. So we decided to look at kind of population health strategies for asthma on the statewide level. And this was funded by the UAMS CTSA Team Science Award. And we wanted to look initially at the association between the quality metric, the asthma medication ratio, or the AMR, and asthma outcomes. And the AMR is really a ratio of controller medication claims to the total number of asthma medication claims, so controllers plus relievers. And we embarked on this using the APCD as the primary data source. Our hypothesis was that if you improved quality of care as measured by the AMR within all populations, it should be associated with a decreased risk of poor asthma outcomes. In other populations, this AMR quality metric has been associated, higher AMRs or improvements in AMRs have been associated with improved outcomes in kids and adults with asthma. So we used the APCD and it looked at children 5 to 18 years old for 2018 and 2019. And then we limited that to Medicaid enrolled children only, and also children with medical and pharmacy claims that were available for analysis. And then lastly, or almost lastly, with at least 1 asthma diagnosis in 2018, and excluded patients with a few other diagnoses, including things like cystic fibrosis and chronic bronchitis and other chronic pulmonary conditions. And we ended up with a population of 22,788 kids with asthma who were continuously Medicaid enrolled in 2018. We found with this preliminary data that if we looked at the asthma medication ratio, it really performed poorly in a broad sample of children to identify the risk of poor outcomes. And specifically, there was poor performance in Black children. So as I mentioned, the AMR, if it improves, you should have better outcomes. And if it's low, you should have worse outcomes. And we found that really for Black children, no matter if you had a high or a low AMR, you still had kind of bad outcomes. So it wasn't able to discriminate between those two, compared to white children where you saw that differences with a higher AMR, you actually did do better, and with lower AMR, you did do worse. And so it really suggested that there must be some differential factors impacting Black kids that were not captured by the AMR, including things like increased ED visits, access to primary care or specialist, compliance problems, physician prescribing patterns, and social determinants of health, of course. And so this led to the next project, which is the KL2 project. And so for this, I really had two aims to look at. So mainly, again, it's a statewide analysis using the APCD, and we're focusing on Medicaid populations for now. And that's mostly because of readily available or more available race ethnicity data. So aim one was really to look at the role of race, ethnicity, and rurality in identifying children at risk for asthma-related acute healthcare utilization across pediatric populations in Arkansas. And then aim two is to develop predictive models linking clinical data, patient sociodemographic variables, including race, ethnicity, and geospatial social determinants of health data, such as rurality versus urbanity, and then something called child opportunity, which I will discuss shortly. Here we identified 25,087 children with asthma in 2019, again, using the Arkansas All-Payer Claims database and using a lot of the similar restrictions from the first project. And we found that we had about 39% of our population was white, 33% were Black, 6% Hispanic, 5% other race ethnicity, which is mostly Asian, American, Pacific Islander, and then people who reported other race, and then 17% who had missing race ethnicity data. About 61% of our population lived in urban areas, and almost 40% lived in rural areas. And if you broke down the urban and rural cohort, you can see the race ethnicity distribution there, where in the urban areas, you had slightly higher rates of Black children, and in the rural areas, slightly higher rates of white children. So the first thing we wanted to look at were asthma adverse event rates, and we looked at this by race and ethnicity. And we found that about 9% of our total sample had an asthma adverse event, which is an ED visit or a hospitalization for asthma in that year. And then we found that 6.7% had an ED visit. Black children had significantly higher numbers, and about 3% had hospitalizations, with white children having slightly higher numbers. When you look at urban and rural, in the rural areas, you had slightly higher adverse event rates with 9.3% versus the urban area with 7.6% asthma adverse event rates. And we can see broken down by ED visits and hospitalizations. And then we looked at kind of patients stratified by outcomes, so if they had an adverse event versus if they did not, and found some interesting characteristics. So in patients with an adverse event, we found that non-Hispanic Black children were the most prevalent group among race ethnicity groups. And then if we looked at comorbid conditions, other underlying conditions, we found some interesting patterns where kids with things like allergic rhinitis and eosinophilic esophagitis actually had no difference in the rates among those with adverse events and those without. But in kids with hypertension, for instance, you had almost a 20-fold increase rate of those among kids with an adverse event versus those without. And then for things like autism, we found the opposite patterns, where more kids were found in the non-adverse event group versus those in the adverse event group. When we looked at other things like healthcare utilization in the year prior and medications, we found something that was similar to what you find in other literature, which is basically that if you had an ED visit or a hospitalization in the year before, you're more likely to have one in the year after. And then when we looked at controllers and relievers, we actually found, these are means, we found pretty low numbers of controllers and relievers among those in adverse event group and those in the without adverse event group, kind of signaling that there's something going on with how much medication is being prescribed to these kids, perhaps inadequate medication prescriptions or inadequate medication claims. And then lastly, looking at oral corticosteroids for the medications, we found higher rates of oral corticosteroids in the adverse event group versus in the without adverse event group. So we looked also at kind of rural urban designation, and then the high RUCA code, so RUCA code 1, which is an urban area. We found higher rates among those in the adverse event group compared to those without, and kind of variable trends among the other RUCA code categories. And then when looking at social determinants of health, we decided to look at ICD-10 codes that are social determinants of health indicators called Z codes. And there was one that kind of stood out called problems related to upbringing, where we found higher rates of this among kids in the adverse event group versus those without. And this problems related to upbringing, you can see on the right, includes a lot of different things, but also things including parent-child conflict, inadequate parental supervision, institutional upbringing, and many other things that you can imagine would impact a child's overall health, including their asthma control. So really the next step for this portion is to develop, to look more at the asthma predictive models, linking all the information, including clinical, sociodemographic, and these social determinants of health, including the rurality and urbanity measures, and the child opportunity, which I'll sort of talk about right next. So the Child Opportunity Index, I think is very interesting. It came out from a group at Brandeis, and it's similar to Social Vulnerability and Area Deprivation Index and a lot of other indices, except it's child focused. And it really is focused on why neighborhoods matter and what kids need where they live to grow into healthy adults. And so it's a composite of 29 area level factors, including things like access to green space, access to healthy food, particulate matter or air pollution, ozone concentration, other things. And it quantifies the relative opportunity of different neighborhoods. There are 3 overall domains, so education, health and environment, and social and economic. And it really looks at those associations among socio-demographic and geospatial factors and outcomes in health. And to note, half of all Arkansas zip codes are in very low or low opportunity areas as designated by the Child Opportunity Index. We have some preliminary data on child opportunity level by rural urban status and by race and ethnicity, and basically found that among rural kids, the majority live in very low and low opportunity areas. And again, this is our asthma cohort. While among urban children, there is a majority, very similar actually to the rural, that live in the very low. But as you get into the higher opportunity levels, you have a kind of higher percentage of urban kids who live there. I would say one of the most stark things that we found is that overall, Black children are more frequently live in very low and low opportunity areas. About 75% of our whole cohort live in those areas compared to other race ethnicity groups, where you can sort of see the variation among those. And then you can also see that when you get to the high and very high areas, there's a very low proportion of Black children who live in those areas. So I'm going to stop there. So we're about almost 15 minutes in. I just want to acknowledge some of my mentors, Dr. Perry, Dr. Jones, Dr. Tilford, and Dr. Gowdy, and then my collaborators, Dr. Brown, Dr. Rezahari, and Arena Iamina, who is a PhD candidate who's been helping with data analysis, and then funding through the CTSA, Arkansas Children's Research Institute, ABI, ACHI, of course, and being able to use the APCD to get this work off the ground, and excited to continue to work on it. So I'm happy to take any questions.
Any questions in the chat?
No questions in the chat yet.
Okay, well, if not, be sure to put them in, and Dr. Jefferson, we can certainly go back to it. All right, that was fascinating. Thank you so much. And social determinants of health, that is the thing these days, and your use of it and the information that was gleaned from it with the claims data was fascinating. I appreciate that. Thank you so much.
Thank you.
All right, let me share my screen again. And okay. All right, our next section today is led by one of ACHI's senior data analysts, Kelly Trillette, and she's going to talk about identifying providers in APCD data. So Kelly, I can forward the slides, we'll start here and you just tell me when to go.
Okay. Hi, everyone. It's a pleasure to be here with you all. I would like to start by introducing some of the sources and variables used when identifying providers. The variables you see here are just for overview purposes. We'll go more into depth with them later. To identify providers, there are multiple tables that are important for different purposes. The APCD claims file can be used to identify a provider's activity or access for providers around the state. The claims file has multiple MPI fields. MC024 is the service provider ID. MC026 is the rendering national provider ID. MC077 is the billing national provider ID. And MC134 is the National Service Organization ID, or the organization NPI. I know it's a lot, but it's important to identify the types of providers early because that determines the fields that will be used in the claims file, but we'll get to that in a bit. The APCD provider file gives us information on the providers, their names, practice locations, specialties, and 3 important identification variables: the license numbers, the national provider identification, or their MPI, and their service provider identification numbers, which we'll use to create what I call the PSI. For providers, it's beneficial to have a third-party source to supplement APCD, as there may be some providers in your study that aren't included in the APCD, such as ones that provide cash-only services. One such third-party source is the National Plan and Provider Enumeration System, or the NPPES. It's a downloadable file that provides similar information to the APCD provider file, such as name, practice location, specialties, license numbers, and NPI. And today, that's the one we'll be using as our third-party source. Next slide, please. So the key variables that are needed from the provider file are PV003, which is our entity type code, and that will separate our providers into groups for proper linkage. PV114 is the submitting entity code, and PV001 is the service provider code. These will be used in combination to create that PSI variable for linking to the claims. And PV023, which is the provider's NPI number. It's an important distinction when working with providers is this entity type code. So we're going to talk a little bit more about that now on the next slide. For the APCD provider table, there are 7 defined categories for the entity type code. These categories are defined by the type of entity that's associated with its federal tax ID. Focus today will be on the first 2, the individuals and the facilities. I want to note that when you're using a third-party table, such as the NPPES, they may not line up perfectly with these categorizations. The NPPES only categorizes individuals and facilities, so those categories 3 through 7 will actually be collapsed into category 2 of facility. So that's just something to keep in mind when you're using these. Next slide, please. So now that we've selected our provider population, we have these 2 groups. We can further reduce the types or use the entire category. Each entity type has different identifiers and uses different variables for analysis. We'll be looking at them separately. From here is defined by their entity type code. We'll first look at entity type 1, which is individuals. This gives us our medical doctors, such as PCPs and specialists, DOs, professional assistants, nurses or counselors, etc. Next slide, please. So for these individuals, if you're looking for a specific type of specialty, you can use their CMS specialty or their taxonomy codes. And to reduce the population on the provider table, these will be found in your variables PV019 for their primary, 020 for secondary, or 021 for their tertiary. There is also the PV025, which is the provider degree field that can help you determine the type of degree for an individual. This is where we can tell if a provider is a licensed social worker or a doctor of osteopathic medicine, a medical doctor, etc. But in using this field, you want to be aware that it's populated through payer submissions and licensure data, and it's an optional field. Next slide, please. So once you've identified your population, your NPI and your PSI can be used to link across their tables. To accomplish this, we're going to use your claims variables MC001, MC024, and MC026. And your provider table variables, PV114, PV001, and PV023. So a provider should only have one NPI, but they can have multiple PSI if they accept multiple payers. If the PSI is created, the PSI, I'm sorry, is a created variable using the submitter code and the service provider identification number, and it must be created on both tables for proper linkage. So to create these linkages, the NPI variable from the provider table is matched with the NPI variable from the claims table. You can see the first set of circles as PV023 is matched with MC026. For the remaining data, you can have your PSI variables matched, where we have PV114 is combined with PV001 to create that PSI, and linked with the combined MC001 and MC024 for the APCD claims PSI. So after doing all this, I have a couple of examples of outcomes that we can look at. The next slide, please. So the first example we have here, providers are split up by our MDs, our PhDs, social workers, and counselors. We have a count for each provider that's licensed in Arkansas, a count for each licensed provider that we found in the APCD through our linkage, and then the number of days serviced where the was calculated from the APCD claims. And then in the second example, the next slide, we have the same categories of MDs, PhDs, social workers, and counselors. And we still have the number of providers licensed in Arkansas and the number of providers that were linked through the APCD claims, but we also incorporated practice location to gauge access across the state. And then we calculated the number of patients each type of provider sees in a year. So those are ways that we can use the provider information for individuals. Next slide. Going back to the types of providers, we can now look at the facilities. To identify facilities, we want to use entity type code 2. This will select our organizations such as hospitals, nursing homes, and other facilities. Next slide. There are a few reasons we separate facilities from individuals for this process. First, the method of reducing the population is different. Second, the linkage requires more of the APCD variables, and some are used in different ways. Starting with selecting the population, one of the ways to reduce the population for organizations is using the type of bill code, which is MC036. The variable consists of 3 digits. The first determines the facility, the second is the classification within that facility, and the third is the frequency. These are all described in Appendix D of the APCD data dictionary, and it lays out a nice table that you can use. For linking to the claims, an organization's NPI can be listed as either the rendering provider, which is the MC026 that we use for the individuals, the billing provider, which is MC077, or as the organization provider ID, which is the MC134. So like the PSI for the individuals, organizations also have a separate identifier, the CCN, and this is listed under MC024. So to properly select all the claims for a facility in your population, each of these variables will need to be part of your linkage as different facilities submit to different fields. The provider table NPI variable PV023 is linked to each of the NPI variables for organizations in the APCD claims table, the rendering NPI, the billing NPI, and the organization NPI. It is possible for a claim line to have only one of these variables populated as well as all 3 populated. So it's very important to pay close attention to the linkage variables when dealing with these facilities. And that's what I have for you today. Thank you for your time, and I welcome any questions now or in the future.
Thank you, Kelly. That was very, very informative. Provider data can appear at the surface very chaotic, and many of our data users have had questions about it. That's really good. All right, and as I said before, you can put a question in the chat or save your questions and submit them later, and we will be happy to address all of them. The next topic is about the data users survey. About 8 weeks ago, we sent a survey to our data users, asking them to participate so that we can, let me go to the next slide, excuse me, there we go. We could collect information about data use, data challenges, and perhaps a wish list. The participants from this data users group and other stakeholders were invited to participate. We received 26 responses altogether. And I'll say, if you did not get a chance, if you did not receive the survey to take, or you didn't get a chance to take it, we will still gladly take it. Let us know, because all of the information that we've received from our users has been so valuable. So we're going to go through some of the key questions and the answers. There were about 25 questions. Ultimately, we're not going to go through all of them, just some of the key ones. So first, we wanted to understand who our users were and where they were from and what their role was. And you can see here the distribution. Most of our data users come from the Arkansas Biosciences Institute, which has a copy, a subscription to the APCD. Dr. Jefferson is part of that. We have several that are non-academic research analysts, state agencies, and then non-ABI faculty. A pretty good distribution. The next question, what is your primary data use? And you could select multiple condition-specific analyses, healthcare utilization, cost analyses, quality assessments, and other, which is asterisk. You can see at the asterisk says education and classroom use, data reporting for submitters and users, providers, submitter population statistics, etc. There were places in the survey, as you know, where you could type in additional information. What would make the Arkansas HTI Healthcare Transparency Initiative data assets more efficient to use? So resolve data tips was one of the options. As you know, every session we talk about data tips, and we will today. Elimination of rarely used fields, stronger enrollment or enrollee member linking, pre-calculated overall out-of-pocket costs. There's another. Episode or event identification, enrollment segment, or continuous coverage roll-up, tools for estimating counts by date, and then member and condition, and then the other, versioning for submitting entity data with no versioning rules, populating optional provider fields. And as Kelly was describing her methodologies for identifying provider data, she did mention that a field or two was considered optional and could be sparsely populated. And this is, other data users had that. I'm not sure Kelly put this in, but other data users have that pain too. So what new data sources would be valuable? Check all that apply. And the winner was self-insured data. As you know, the Arkansas All-Payer Claims Database has fully insured data. Self-insured data from state agencies like Employee Benefits Division, but mostly it's fully insured with Medicare and Medicaid. Also, Medicare fee-for-service data available to non-state agency users. More recent medical marijuana cardholder data, electronic health records was very popular. Other included hospital discharge data for the insured, as well as the uninsured and self-pay, which is what we have now. Medicare chronic conditions warehouse data, etc. I believe that we can get the Medicare chronic conditions warehouse data in the next year. That I believe we can accomplish and be successful. What targeted or subject-specific data sets would be valuable? Our idea behind this was that perhaps there are analytic files we could produce from the APCD that would make your work easier. Members with continuous coverage and all associated claims, condition-specific data sets, master provider file, age-specific data sets like children versus adults versus senior, other, and survey participants wrote cleanly linkable data with minimal duplication, demographic data supporting member data, etc. And duplication is, we interpreted that to mean helping identify TPA and PBMs, because sometimes they're if a carrier utilizes a PBM for their pharmacy, their members will have a member record from the medical claim, and then they'll have a separate member record for the PBM. And there's an art to bringing all of that together. In summary, after all the survey responses were captured, discussions were held with several APCD super users. You're all super users, but we held about 10 calls to distill results, and consistent themes emerged. Analysts spent most time with enrollment data to understand coverage and enrollment. Stronger enrollment and claim linking would be helpful. And with the addition of self-insured data, electronic health records, those types of additional data sources would provide most valuable. So from this information, we are working on some data assets that we can provide in addition to the raw claims. And as I said in the beginning, the all payer claims database is big and complex, and do not hesitate to reach out if you need help with it. But hopefully the data assets that we can design from this input will be helpful to data users in the future. And there's some in the queue, not ready to announce or provide prime time, but this information was very valuable and helped guide us to our next steps. Once again, if your input is still valuable, if you did not get to take the survey, let us know. We'll send you the link and include your feedback in the overall results. Looking for suggestions everywhere. All right. Does anybody have any questions, or is there those of you who took the survey, or anybody, can you provide any feedback? What would make your use of the data more helpful? Happy to take anything, discuss it here. I know, put you on the spot. Again, don't hesitate to reach out, because we want to make our data easier to use and more valuable to you. Your input is critical. All right, next, go to the next section. Latest APCD release information and data tips. Now this slide is largely unchanged from the last time in January. We have released data through June 30th, 2022. There are some data that are a little newer. Some go through September of 22, but officially it's through June. And the data user resources, all of these these links are live, so that when you get the email with this deck in it, you'll be able to go to all of these data user resources. And I will say every time, be sure to review the data attributes deck you can see here in the blue box, because it will help you through linking the data using the study ID, or some call it the hash ID. There's the link to the data dictionary that Kelly mentioned in her presentation. But I wanted to spend a couple of slides on something that's changed in this update. We have a submitting entity called the Employee Benefits Division, EBD, and this is a state agency that manages health insurance for Arkansas state employees and Arkansas public school teachers. And we've had this data for a very long time. It's been in the APCD since the beginning, and has been identified with the submitting entity ID ME001 equal to 99 EBD1. Well, in May of 2022, we stopped getting the data. We used to get data directly from EBD. We got their enrollment data, their medical claims, and their pharmacy claims. We got some data from their TPAs, but the primary data source was from EBD proper. There were data tips to govern how to manage the TPAs. So the EBD's primary TPA is Arkansas Blue Cross Blue Shield Health Advantage. And in June of 2022, we started to get the EBD data from Health Advantage and not EBD. So there are some nuances here. And unfortunately, right now, that means that if you wanted to get the entire EBD universe, if that was your target, you would have to do a couple of things to be sure to get it all. And this slide and the next slide talk about what is going on. It doesn't give you directions, but gives you links to directions where you might find how to manage these data now. But for example, medical claims for EBD medical claims for 2013 and 14 we consider them historical, and they still fall under 99 EBD1. Thereafter, medical claims come from Blue Cross Blue Shield Health Advantage, and that is ME001 equal 95442. The pharmacy claims from 13 to May 2022 come from EBD. I'm so sorry. And then thereafter, from June 2022, these data will be sourced from EBD's new PBM, Pharmacy Benefits Manager, MedImpact. The MedImpact data is not ready just yet, so we only have pharmacy claims for EBD in May of 2022. There are a couple of other things that are helpful, how to identify retirees and those with no health insurance. I'm not sure we ever spoke of those before, but I included them here. So there are data tips out there that will help you as you use these data. And these are the three. The last one is the big one that describes how to select the new data. And we have SQL code in there. We don't have SAS code. We have SQL code in there that can help you understand and select these data. So our goal is in the next build or two to be able to set a flag somewhere that you can use to select EBD data instead of having to go through all these machinations. That is not available yet. We are working on it, but you needed to understand how dramatically the selection of these data changed. So I'll stop there. Does anybody have any questions? It's a lot to take in, and maybe you need to just go read everything and then reach back out to us. But does anybody have any questions about this change?
So far, no questions.
Thank you, Jane. All right. Don't forget, always check your data tips. And so as you go out to the website, or if you should be getting a monthly email with the latest data tips, and it should have enable you to click through to it. So be sure to get that. If you don't get that email, let us know and we'll put you on the distribution list. One of the changes that is beginning to happen is that we are changing a term. In the past, we have this term called hash ID, which is the concatenation of ME998 and ME013. And we are, to align with Arkansas, the ACHI analytic team, we are changing that to study ID. And you'll begin to see it in all of the documentation and the data tips, et cetera. So be aware of that. It used to be the hash ID, and now it's the study ID. And one last thing, I have put a button on the Arkansas homepage, the Arkansas APCD homepage, to get to the data users group presentations, because when I built this deck 2 weeks ago, I bet I went through 4 layers of link and link and link to try to find it from last time. And I thought, no, we need this. We need it to be readily available. So I put a button to it on our homepage so that everyone can access it. And in the past month or so, a few data users have asked for information that was answered through the data users group slides and presentations. So this will just make it easier for everyone. All right. Reach out to us. Absolutely. We are here to help. And then to close, next meeting is July 26th. I managed to get through with 14 minutes to spare. This is an opportunity for anyone to ask questions. Is there anyone on the, excuse me, is there anyone out there who did not get a chance to take the survey and would like to? Understood? Your input and about the use of your use of our data is incredibly valuable. We know a lot about our data, but the users know it in a different context, and you see what looks strange faster than we do, and we appreciate every one of you. So, if there's nothing else, then I'm going to give you back 13 minutes. Thank you so much, and we will see you in July. I believe our guest speaker is going to be one of our key data users externally from a group called Decision Queue. They have already promised to be the headliner for the July meeting. Thank you very much. Reach out if you have questions.